Welcome everyone. We're just letting everybody get into the room and settle in, and we will get started in a moment. Okay, I see that we have a few more people just filing in. So we'll get started just in a few seconds. And just a question, can everyone see my slides? Okay, perfect, thank you. Okay. I still see the numbers going up, so I want to just, like I said, give it a few more seconds. Okay, wonderful. I think everyone who was in the waiting room has now joined us, and I really want to get started so we can pass it on to our wonderful speakers today. So welcome everyone, really excited to have you here. As the title mentions, this is Finding a Way Forward. It's about retaining and recruiting MAs and DAs in the changing workforce landscape. This is part one, so today we're going to focus specifically on medical assistants, and we have two experts who speak to you today on what it's like to retain and recruit MAs. As we know, this is a huge area of concern for health centers. We just keep hearing this across the board, how hard it is to recruit, many times based on compensation, and then to retain. So we really want to look at a lot of different interventions that we can use, and our speakers will talk about that today. But I just want to give you some context of who we are. So we're the Association of Clinicians for the Underserved. So you can see here, we have a goal of increasing access to care and supporting primary care clinicians. We look at it from a policy, practice, and workforce lens, and focused along all types of clinical workforce, so medical, behavioral health, vision, oral health, and we were founded by National Health Service Corps alumni, so it's still really the foundation of what we do. Today's webinar is brought to you with one of the programs that we have, which is called the STAR Center. So that's why you're here today, and all of our resources are free, our training, our technical assistance. So if you want to contact us, you could reach us here, as well as our website, and that email actually goes directly to me, so you'll always have someone who will answer you back. And then I see that we have a comment in the chat. And Denise, so the slides are going to be available after the session, so we're going to make sure to send them. Yes. I don't believe that they can be downloaded during the session, unfortunately, but everyone will be able to get a copy of the slides afterwards. So this session is being recorded. It's going to be sent via email to everyone who registered, including the slides. You can use the chat box to ask any questions, share comments or thoughts. We were going to make sure to leave time for a Q&A at the end. If you do have any technical problems, contact Helen Ravenier. She will be able to help you, and please complete our evaluation at the end. We would really greatly appreciate that. And as I mentioned with the sharing of the slides, we always like to point out what's new at the STAR Center. So we have worked building a definition for a comprehensive workforce plan. This is the HRSA approved definition. We're also working on the difference between a comprehensive workforce plan, a strategic workforce plan. We have many different things. Our newest podcast season is wonderful, really focused on employee wellness. So just wanted to highlight a few of those things. And all of these are hyperlinked, so when you get the slides after the presentation, you'll have the chance to click on them and go directly to it. So really, the highlight of today is having our two wonderful presenters. So we have Elena C. Thomas-Faulkner. She is the Chief Executive Director and the School Director of the National Institute for Medical Assistant Advancement. And we also have Dr. Mary Blankson, and she is the Chief Nursing Officer for Community Health Center, Inc. So just to give a little bit of background, NIMAA is a Colorado-based nonprofit and national accredited post-secondary vocational school they train medical assistants to work effectively in primary care settings. So really, you know, we are bringing in the experts who are hopefully going to give you great information. And as I mentioned, Elena Thomas Faulkner, she is the Chief Executive Officer at NIMAA. She has over 20 years of experience in organizational leadership, management, and development that she brings to her role at NIMAA. And Dr. Blankson, the Chief Nursing Officer for Community Health Center, Inc., oversees the diverse nursing services that are offered across CHC, Inc., including both registered, licensed practical nurses, and medical assistants. So with that, I am going to stop sharing my slides and pass it over to our speakers who will be sharing their slides.
Thank you so much. We're so delighted to be here today, and I'm going to just try and get this slideshow going from the beginning. I have to move some bars around on my screen. All right, are you able to see that now?
Not quite yet.
Yeah, it is loading right now. That's what there we go.
Okay, now you're able to see it? Great. So just a real pleasure to be here today to talk with you all about this really important topic that we know has become even more urgent as we move into sort of the ramifications of COVID on workforce. We know that many folks have been struggling with medical assistant recruitment and retention even before COVID, and now it's even more critical. So just really pleased to be here with you today. And we have three main objectives that we want to cover. A lot of information actually, so I'm going to speak a little quickly, but feel free to throw something in the chat if you want me to slow down or respond to questions during the presentation. We're going to talk about an education-based medical assistant recruitment and retention strategy, meaning how can your participation or collaboration with a training program help to differentiate you from other folks that are looking to hire medical assistants within your community. So I'll talk about that a little bit. Then Dr. Blankson will identify some characteristics of medical assistant training that are really important for practice in a team-based care setting and for setting up, again, for that strong retention and performance of medical assistants in that role. And then we'll talk some about how to build a career ladder for medical assistants within your practice. So those are the three main areas that we're going to focus on today. And before we get into the weeds on that a little bit, I just want to provide some context about like, why is this so hard right now? Why are we struggling so much with medical assistant recruitment and retention? And, you know, there's two things going on here. One is this is a really growing field. Like as primary care develops and as more folks really look at that team-based care practice, the role of the medical assistant becomes even more critical, I think, and there's more demand for medical assistants. So we definitely have a growth in this job category. This 18% growth is one of the highest growth categories in our economy. So there's, you know, that happening across the primary care sector where there's just more positions being developed for medical assistants. You see here there's 104,000 openings annually and 132,000 sort of new medical assisting jobs that'll happen over the next 10 years. So a real need to expand the workforce, and that's part of what you're feeling in your challenges. And then just as we talk about the medical assistant role and looking at, these are national numbers in terms of the median income and hourly wage for medical assistants, this is a position that for a single person, it can offer a livable wage. But it's definitely on the scale of wage where there's a lot of sensitivity to what that wage is and where there are a lot of needs that folks that are in this wage range face on a daily basis in terms of competing demands for what their income is able to cover. And so we'll talk a little bit about that in the price sensitivity, which I'm sure everyone on this call is also struggling with and very familiar with. A little bit about what the medical assisting workforce looks like. So I don't think these will be a surprise to anyone, you know, primarily female, Average age of 36, this is really important. And at NIMAA, when we look at applicants to our program, we've got those folks that are directly out of high school, but we have folks coming in, who've been out of the workforce, or maybe they've been working as a CNA or in another role in a health clinic. So that there's really, you can pull folks from a wide range of life experience into this role and engage them in your practice. A real opportunity there in terms of the age at which folks will enter into a health career through the medical assistant doorway. And then we see that the current medical assisting workforce is a pretty diverse workforce. And that is something that provides a real opportunity, I think, for making sure we maintain that diversity, but also leveraging the diversity that we have within the medical assisting role to create those more diverse pipelines to other roles within our organizations as well. So we'll talk about that here as we move forward. For NIMAA, this is a really important piece of how we work as a school, really wanting to make sure that our student body reflects the diversity of the communities where those students reside. Another thing to note in terms of the training that most medical assistants receive has been historically and continues to this day to be through for-profit schools, some of which leave the students with a lot of debt and makes them even more sensitive to wage differentials. So just something to be aware of as you're thinking about school partnerships and about what's motivating and impacting your medical assistant workforce. So I just want to share a little bit about NIMAA so you know kind of the perspective that we're presenting from. I'm not going to go into a lot of detail about our model, but we were formed in 2016 by two community health centers, Community Health Center Inc. in Connecticut and Salute Family Health Center here in Colorado, really to respond to the challenges that they were seeing in their medical assistant workforce and that we have found are common across the country. And those challenges were really hiring medical assistants that they then found had to be retrained to their model of care, who perhaps had not had any substantive experience in a full primary care practice as part of their training. And then again, who often came in with a lot of debt that limited their ability to really be where they wanted to be and focus on the mission of the community health center or other community-based practice that they were in, made them very sensitive to wage differentials. So our model was designed really to respond to those specific needs that they saw. And what we developed was an online training program so that our didactic program is offered asynchronously. Students can do their online work at a time, for the most part, that works for them. And that gives them some flexibility so they can maintain a part-time job, they can attend to family matters. It really allows us to engage a community or students, where they are in their lives and what fits for them. We also have a concurrent externship experience. So students are in clinic from day one of the program. And that does two things. One, it really engages the types of learners that we're working with so that they've got that hands-on experience. And two, it really immerses them in that clinical environment so that by the time they're done with the 8-month program, they know how all the systems work. They know what the quality improvement goals are. They know, how the patient flow operates. So it's a much different experience than they're trying to do a capstone 4 to 6 weeks at the end of their program. And then we really focus on making sure that medical assistants have that orientation to team-based care and the skills related to that. So that's an additional set of content that we have within our program that isn't covered in most medical assisting programs. The last piece is to try and make the program really affordable. So our tuition is set at $6,000. Our fees are $785. So that's comparable to what a community college would be. A shorter program than most community college programs, and it's certainly much more affordable than one of the private schools. So this is just currently where we're providing our program. So the states that have the green stars in them are where we have clinical partners and where we're enrolling students. The states in blue are states where we've gone through the regulatory processes necessary to be able to offer our program. And so, can certainly engage with clinical partners there. And then we do have to go state by state to get approval to offer our program. And so the ones in white simply mean we haven't yet talked with the clinical partners there. And I'll talk a little bit about how our process really starts with engaging clinical partners And then we look for students from their community rather than enrolling students and then looking for a clinical placement, which is the traditional model. So let me make a quick case for how working with an educational program, whether it's NIMAA or another program, and really supporting the education of your staff in MA roles can help give you a bit of a competitive edge in terms of recruitment and can help support employee retention as well. So in our recruitment model, as I mentioned, we start with the clinical partner. So we find the clinical organization that's interested in hosting students that has a team-based care model. And then we really work with them to recruit students from the community. And this is the kind of partnership you could do with other schools as well. But it takes some dedicated staff involvement at the clinic and some thinking about, how can we leverage our networks to get the kinds of students in educational programs that we want to have as employees. One of the things that's very effective with our partners is to have a chief clinical person or an administrator send out an email to staff and say, hey, we're partnering with this program. Let folks know about this opportunity. That to date is our highest leverage marketing that we do, even though we do all the social media types of things as well. So really thinking about the mission of community health centers and other safety net providers to provide those opportunities, economic opportunities and education opportunities within the community. How can you do that from the beginning in helping to engage folks in educational programs? We also include our clinical partners as part of our admissions interview. So students do an interview with our staff, but they also do an interview with our clinical partners. And that's really important too for the clinical partners are thinking about an eventual employment outcome, as is the student. It also gives the student a chance to think about, okay, this is where I would do my clinical rotation. This is where I would like to work. Does that work geographically? Is this kind of what I expected? So sort of that check for them to think about the commitment that they're making in the program and having that opportunity, whether it's part of an engagement process in an educational program or outreach to students, high school students, or to job seekers in your community that allows folks to come into the clinic, see the environment, get a feel for what that's like. It can be really critical to helping to support these kinds of recruitment pieces rather than starting just at the time that you're looking for job applicants for a specific position. So here are just some quotes from some of our applicants about what motivated them. And this is our most recent group of students that are applying for our spring 22 semester. And you'll see that there's a couple here that talk about, they really want to be able to give back to their community and knowing that there's a program like this that will support them. So that's that affinity with the mission. That I know is part of what you all have found at ACU is through some of the work that you've done already is something that we know helps to recruit and retain people into our program. Here you see someone whose mother got the email. So again, just working through those networks that we have in terms of letting folks know about the program. And then these other two quotes that are up higher on the top are really about an advancement opportunity within the clinic. And we see this as a very successful workforce pipeline piece as well. You can start with medical assisting as the first piece in a pipeline, but there's other roles at health centers that feed into medical assisting. So the front desk role, the outreach role, sometimes it's the financial screener, can those folks move into a medical assisting role? And when they've seen what that role involves, because they're in the clinic, they're great candidates for moving on to medical assisting. So before I wrap up this part and hand it over to Mary, I just want to talk a little bit about the kinds of investments that some, not all of our partners, make in students that are participating in a program like NIMAA. So we do have some partners that support a portion or all of the tuition that students need to get through the program. And that does a couple of things. It conveys to that student sort of the commitment, or to that employee or community member, we'll invest in you as an individual. We value what you bring to our organization. And it also provides a chance then for the clinic to engage in a service agreement with that student that says, once you're done with your program, if we choose to hire you, you commit to staying with us for X number of years because we've supported you in your schooling. So that's a very effective both recruitment and retention tool at the same time. The other thing that we often see in terms of partner investments, and this has to do with, moving from an entry position at the clinic, moving into medical assisting, and that is really just accommodating what it takes to engage in an educational program. So allowing the employee to reduce their hours in their current position, figuring out how can we do that in a way that still allows us to operate as a clinic, and how can we help the employee maintain, even if they're getting an income cut, at least maintain the benefits that they need, or that their family needs while they're in the program. Again, that helps with that retention piece. Employees recognize, hey, this organization invests in me, and I'm going to look here for the opportunities for advancement. So I will look at the messages in the chat as Mary is covering this next topic and circle back to them a little bit later, but I want to introduce Dr. Blankson and invite her to talk about the characteristics of medical assistant training that can really support that team-based care practice.
Great, thank you so much, Elena. If you can go ahead and let me see. Perfect. Great. So what you'll see right now on your screen, this is just a map of the state of Connecticut. So this is my home state where I'm presenting from right now. And Community Health Center, Inc. is a large federally qualified health center here in the state of Connecticut. We're actually one of the largest in the country, and we have a whole group of about 14 or 15 brick and mortar sites across the state that are fully integrated, medical, dental, behavioral health. But then, of course, a significant number, about 36 integrated school-based health centers with medical, behavioral health, and mobile dental, as well as about another kind of 70 or 80 school-based health centers that are really behavioral health only. Other mobile programs with our farm workers and healthcare for the homeless sites. So we kind of do a little bit of everything, which definitely keeps me on my toes. And as you can imagine, it means I have medical assistants kind of doing a little bit of everything as well across our entire network. Our huge focus, of course, as most health centers are, is focused on clinical excellence, but really with a hefty focus on research and development, as well as training the next generation. We implement a lot of strategies on how to build workforce pipelines, but utilizing educational interventions. So, this opportunity with NIMAA has really been wonderful for us as a health center, as a part of our recruitment strategies. And I'll talk more about that in a little bit. So next slide. So first, just want to share a little bit about kind of the role of the medical assistant in team-based care. So for many of us, right, the hallmark of a well-performing medical assistant is not only do they perform, the rooming process, whether that's in virtual or telehealth care or in-person care, but they really have the opportunity to welcome the patient into the clinical area of the health center and then perform what we call planned care. So that may be routine cancer screening, or chronic disease care, such as foot checks or retinal screenings for diabetics, other types of interventions that are really motivated based on the patient's age, their sex at birth, their chronic disease status, and others. They also perform delegated ordering through many of these. So that could be ordering the mammogram that's due, the colonoscopy that's due, as well as performing what we call panel management, which is really when you identify these care gap reports or other population health-based reports where patients may be lost to follow-up or may have other care gaps that really need to be focused on, whether it's for your uniform data system metrics or maybe for a value-based care contract, but really making sure that that patient is getting the quality level care that they need and deserve. Of course, medical assistants do bear the brunt of our administrative workflows, whether that's prior authorizations, faxing, like you name it. If it involves paper, electronic paper or regular paper, the MA is typically the one who handles it. They also handle a lot of our devices. So for us, a lot of it's retinal camera operation. They might do spirometry. There's a lot of different devices and screening tools that we utilize in the primary care setting that require medical assistants to have specialized training on how to use specific devices. And then lastly, kind of this involvement in what it means to perform quality improvement and practice transformation. So medical assistants oftentimes are extremely involved in this, and we'll talk about the main reason why in a moment. Next slide. So when we think about the business case for medical assistants, I think the things that you always want to keep in mind, because obviously when you talk about these roles, so you probably are like me and you spend a lot of time in your CFO's office really saying, can we please, please, please talk about our medical assistants for a minute? Because, you know, oftentimes they get stuck on conversations related to provider retention and other issues that, you know, of course, are extremely important, but they don't necessarily understand or realize that MA satisfaction and support staff satisfaction is heavily linked to provider satisfaction and provider retention. So again, they may be able to better understand kind of the hard dollars lost should they lose a provider, but they have to understand what are the reasons why we lose providers, which one of the number one reasons why clinicians turn over in primary care is related to workload and burnout because they don't feel like they have adequate support to manage the panel that they're managing. So when we think about the role of the MA, we always have to remember that they are absolutely a very, very valuable clinical team member, right? They are not just sort of the downstream dumping ground, which again, I'll sort of go into in a moment, but they actually are a direct link to revenue generation, right? So a lot of times, particularly in our value-based contracts, in our UDS measures, in our you know, our HEDIS measures, you name it, those medical assistants are the ones who are typically entering the structured data that we then pull out of our systems to measure and then report in order to be able to get shared savings or, you know, to hopefully turn out on the positive side of an at-risk situation or other types of value-based arrangements. As I said before, provider satisfaction and retention is heavily linked to the amount of support and the quality of the support that a provider has. So sure, maybe they have a medical assistant, but is that medical assistant really performing in a way that is beneficial and supportive to that provider and the panel of patients that they are related to? Patient satisfaction with visit flow and efficiency. I think we all know that FQHC providers do at times run behind. You know, we oftentimes have 20, 25, and it's not even FQHC patients, it's really primary care patients, right? We have 20 minutes, 25 minutes sometimes to see a patient. And the patient comes with 6 or 7 different chief complaints at times. So how does the medical assistant really support that, right? They communicate with the patient, let them know where the provider's at in the schedule. They accomplish lots of other items on behalf of the patient while they're waiting to be seen by the provider. Sometimes they invite in other care team members, maybe the dental hygienist to do fluoride varnish, maybe a behavioral health clinician to talk about a warm handoff because of a positive behavioral health screen, really making sure that the choreography of the patient visit is well managed so the patient has a great experience, right? They also, as I said before, are the direct link to quality measure and data capture. And lastly, they prevent waste in supplies and other workflows, right? They're the ones who are supposed to better understand what your PAR levels are of medications, of devices, of other medical supplies, and make sure that you don't have too much on hand and that you're not actually wasting. Next slide. So you always have to focus on strategies around culture change. And I think these are kind of pet peeves of mine that I talk about a lot because it's really easy to fall into these danger zones, right? So when you're thinking about a medical assistant being a critical member of the care team, that is really the heart and focus of your conversation. You have to be careful that when you start to talk about work moving downstream away from providers, that is the only way that then you include the medical assistant as a part of your conversation, right? They are not the downstream dumping ground. They are in fact a highly qualified and highly trained individual who is really good at structured data and kind of the black and white, right? Whereas providers oftentimes think in shades of gray, right? We're always thinking in the individual case, not so much in the larger trends. And so really to have an effective team-based model of care, we want to leverage each member of the care team's individual contribution that can be beneficial. So if we're constantly talking about how we want to preserve our providers, save our providers, move this work downstream because you don't need a provider to do it, although that makes the providers feel really great that you're considering me, that you are taking care of me, that you really want to make sure I'm not overburdened, to a medical assistant, it feels like you aren't considering me, you aren't thinking about me. I'm just sort of who comes next in line or further down the line than maybe some others. So it's very, very important that we talk about critical care team members as really taking on the things that they are best at doing, right? And that does happen to move things downstream from the provider, which is really beneficial. But the culture and the words that you use, the terminology that you use is vitally important. Next, I think it's important that when you talk about a medical assistant, back one just for a quick second, sorry, is that you talk about the medical assistant role as being impaneled to the patient panel. Not necessarily that they are assigned to that provider, right? But they support this panel of patients. And that just really helps. So if that patient is seeing a psychiatrist or seeing another care clinician on the care team, the medical assistant can assist, right? Because it's not just about me making sure that this nurse practitioner or this physician or this PA is functioning well and that their clinic is going well, but it's that this group of patients is getting the support that they need to be successful. And creating that measurement culture where I am accountable to my depression screening rates and I'm accountable to my mammogram ordering rates, because that is something that is 100% in my authority and my responsibility to do. So again, accountability in your performance appraisals become less about, am I a good team player? Do I have a positive attitude? And a little bit more about how do I execute on making sure that this data is captured and that it's entered properly and accurately so that we can really demonstrate the quality care that we are committed to every day. Next slide. So when we think about organizational requirements of MAs, right, we always want our MAs to be flexible. We want them to be critically thinking. We want them to sort of be a jack of all trades and a master of everything, right? So whether I float them to prenatal or float them to pediatrics or float them to another clinic, they're able to function and be successful. We want them to be positive in the face of change, right? So if we change 47 of their workflows in 2 weeks, that they're going to attack that with positivity, and that they're going to move on from that and be ready to take it on and be successful. And that they have appropriate problem solving, right? So they don't just throw their hands up, but they actually come with solutions that they're ready to implement. That's a lot to ask of staff, especially, during the COVID-19 pandemic, during primary care just in general, which is by far, I think, the most challenging discipline to practice because of that requirement that you are a jack of all trades and a master of everything. Next slide. So we have to also think about what are the things that our MA staff need to be successful. And a lot of these things aren't necessarily things that are that big a lift for us organizationally, but they are things that require us to place focus and structure and to create some documents and some other supports for our medical assistant teams. So first, it's important to note that your MA staff, first of all, tend to be much more culturally and linguistically concordant with the community and with the mission of what you are performing at your health center, right? They tend to look a lot more like the populations that you're serving, which increases their value even more, right? Sometimes that may come in as simple as a reduction in translation costs, because you have, medical assistants who speak the language. Those are all benefits that should be taken into consideration when developing your medical assistant workforce and costs that we can actually save. But it also increases their job satisfaction because folks who are taking care of people who they grew up with, who they know about, communities that they're actually woven into the fabric of that community, they tend to be in it for the long haul because they see the value. And even on the hardest of days, they will be able to actually connect with that mission. So meaningful work and really feeling like, again, I'm not a dumping ground, but I really am a valued contributor to the overall care team really does bring satisfaction to this particular team. The fact that they have some control and autonomy. So whether that's through standing orders or through your planned care model, that they really, again, feel like they are the masters of their job. They are the ones who know this is what I'm supposed to do and I don't have to ask for permission every single time, but I know that this is the right thing for this patient because of their age, because of their sex at birth, because they're diabetic or whatever the case may be, that they can just act on that data and information. Again, they want to be able to keep a broad skill set. It's very difficult for some medical assistants to find jobs when they have externships or other experiences where they're working at, for example, a subspecialty clinic, or sometimes I'm seeing actually an uptick in externships that are taking place at weight loss clinics or at cosmetic dermatology clinics, where again, a lot of the skills that they're presenting are, creating a sterile field, hand hygiene, maybe a few tests at the subspecialty clinics, but not the variety of CLIA waive tests, not the complexity of patient complaints and age groups that we deal with in a primary care setting. So these are very attractive jobs because of the fact that they have that broad skill set. So that's something that you want to share with them and say, hey, you know, when you come here, you would have the opportunity no matter where you want to go after this, because you'll have such a broad skill set. Again, they do contribute very much to the patient experience and the overall sense of team. Next slide. So when we think about sort of a team-based care sort of educational components, I think it's really, really important, because medical assistants that are coming out of traditional programs don't necessarily get all the things that they need to be successful in today's primary care field, right? So when we think about some of the content that they're lacking that we do integrate into NIMAA, but also just in general as a part of our onboarding, most health centers, right, we're teaching them about what does it mean to be a part of an interprofessional team? What does care coordination look like? And how do we make sure that we can balance care coordination and everybody understands everybody else's role on that care coordination team? They understand some basic level of health coaching, right? How do I talk to a patient who's thinking about quitting smoking so I can help them to hopefully reduce the number of cigarettes that they're smoking a day? That they have that sort of critical thinking and level of professionalism where we know that they can continue to climb the ladder at our center or at our clinic to be able to be successful. And then, of course, those telehealth components, right? How do we conduct rooming of a patient over the telephone or over video in an effective way where we can still collect a lot of data on the patient to actually move the needle on our planned care huddles, even though we can't physically touch the patient. Next slide. So lastly, we're going to go ahead and talk a little bit about MA career ladders and a little bit about retention in general. So next slide. So when we think of sort of the CHC experience, I'm going to share a little bit about kind of our personal journey. So I'm going to talk a little bit about some historical recruitment and retention strategies, and then talk about some of the new strategies that we've implemented. This does say current data. I'm still analyzing like my 2020, 2021 data, because of course, COVID has definitely blown things up a little bit. Although certainly I know, you know, for better or for worse, we are definitely not struggling as much as some regions are, I know. But then talk a little bit about our path forward for our ladder program creation, which we are in the thick of, and I have an upcoming deadline for as of our next fiscal year to do our full implementation. Next slide. So first, when we look at historical recruitment practices, we're thinking traditional externship students coming in, right? They've spent an entire chunk of time in their program practicing in a lab setting on other students. And then they're coming into our health center in that traditional externship, which is, you know, a certain number of hours that they will work with us, where they have to kind of take everything that they've learned and put it all together. And be confident about it, right? So that our medical assistants feel safe kind of having them work with them on the floors. Then oftentimes, you know, the onboarding experience, if let's say we didn't do the traditional externship program, but they finished their externship maybe at a local, as I said, weight loss clinic or cosmetic dermatology clinic, or maybe an orthopedics office, they really don't come with all the skills and experience that we need for primary care. So the onboarding experience often feels like we're reduplicating all of their labs that they had during their actual paid program, as well as then doing the onboarding for our successful program, which sometimes means that it takes, you know, 4 months before a medical assistant is ready to hit the floor. And again, that's really challenging when your medical assistant only is required to give you 2 weeks notice, right? So if it's 2 weeks to lose them, but then 3 to 4 months before they're up and running, I mean, it's just really, really challenging for health centers to kind of get ahead with regard to recruitment and retention. So at just what I was just saying, this sort of this time to replace, if I know it's going to take me 3 to 4 months to replace a medical assistant, even outside of sort of that recruitment piece of it, right? HR will tell me, oh, I'm doing well. My vacancy rate is really well, because they're looking at time to recruit. But I, as a CNO, am looking at time to replace because that person isn't ready to go for at least 3 months in. So I'm thinking I actually have to be ahead of my vacancy rate in order to keep up. Which means I have to have full-time, fully benefited float positions or other types of positions that kind of queue up the next person to be ready when I get that 2-week resignation. And that kind of thinking, I think, is very, it's a little hard at times to convince our CFOs, to convince our you won't have to try hard to convince the CMO because they'll be like, yes, my providers want to be happy and they want to be supported. So please, get this staffing for me. But it's very, very important. And if you look historically, you should be able to make the argument with your HR team that your time to actually replace, because of the length of it, you do need to be ahead. So sometimes that takes a little bit of work to kind of map it out with your resignations, with some of your turnover, but it really will pay off in the end. Again, reinforce that link to provider retention. And currently, prior to our beginning of our implementation of our ladder program, we had a 2-step ladder program, regular staff MA and a senior MA. Next slide. So when we think about new strategies, first, our academic partnerships have been absolutely vital for us. So I am looking to have as many NIMAA students as possible in my health center because pretty much 100% of them, maybe except for one student who went into a nursing program directly after finishing NIMAA, I've hired all of them. And the majority of them actually still work for the health center. And the beauty of it is that we invest in their education, but yet they are really becoming experts at CHC. So by the time they graduate from the NIMAA program, they can actually hit the ground running. Of course, they still get their probationary period, they still get their standard trainings, but a lot of it is really refining their skills more than anything else because they really know their way around our health record, they know their way around our health center, and know their way around our model of care, which definitely makes life a lot easier. Particularly now that we have 2 cohorts going through. I have 2 graduation timelines where I'm looking at my basic vacancy rates and looking at my graduating students and thinking, okay, these people are in this region or that region, so this is who I want to move. And I might actually take on an extra graduate in a region thinking that I'm preparing for some potential turnover. And so oftentimes, particularly supporting students who have been dedicated to CHC, they've come here for the NIMAA program, that's been significantly beneficial. We still do take from time, especially during COVID, I did start to take a few kind of traditional externship folks again, mainly because a lot of places were no longer taking students. And I really wanted to make sure that our local schools were supported as much as possible. And because our vacancy rates at time were higher than what, even our NIMAA program could actually supply to us for students. So there is still some room, obviously, for local arrangements as well. Again, that sort of time to replace versus time to recruit is really, really important. And then I'm just going to skip down to staff compensation. Connecticut's living wage has really, estimates have really gone up. And so this year, our 50th anniversary, we are going to be moving to a $20 an hour minimum wage. Which again is a huge undertaking. It is creating a lot of wage compression for my medical assistants, but I've been working on this proposal for about a year now so that we can again really work to focus on what is the revenue that we truly generate because of the work of our medical assistants and because of that data capture, and how can we capitalize on that and improve our retention rates through keeping our salaries competitive. As you all know, during the COVID-19 pandemic, wage inflation has definitely been something that we've all struggled with. Next slide. This is just sort of a 2019 market analysis. So again, this is old data. So if you think now sort of 75th percentile, when you look at our base, it was at 1845 and our total comp was about 1875. We really focused for our medical assistants on being at the 75th or the 90th percentile in terms of wages. For some of our other staff teams, we really focused more on being at the 50th percentile. But again, when you're at those entry-level positions, oftentimes you're not even anywhere near a living wage. And so again, your staff will leave your organization simply for a slightly higher salary, no matter how well you do in any of those other retention strategies, because they really need to be able to put food on the table, and they don't want to have to work 2 jobs, right? So again, sometimes a little bit of an increase in pay actually makes a huge difference in your ability to be able to retain individuals in your positions. Next slide. Again, this is in thinking about our ladder program. This is where our staff ranges were. So again, back in 2019, our staff MA ranges ranged anywhere from 1850 to 2269, and our senior ranges were actually 1950 to 2358. So as you can imagine now, if everybody moves to 20, there really is wage compression, particularly given the amount of turnover that's occurred during the COVID-19 pandemic. Next slide. So this is just some basic data that, again, you can look at this slide a little bit later on, but I think one of the things that you should consider when talking to your HR department about even measuring retention or turnover is really thinking about, first of all, involuntary turnover, which means we terminated the individual, and voluntary turnover, which means they elected to leave the organization. But you also want to look at turnover that I see. I call it turnover, but HR doesn't necessarily call it turnover because the person maybe left a full-time job, but then turned to a per diem employee. So maybe they still pick up some Saturdays, they still pick up some evening shifts, whatever the case may be. But they're really only keeping that because A, they're tied to the mission, but they likely found a higher wage somewhere else. That still should be counted as turnover. So sometimes that means you have to manually go through your staff list over the course of the last couple of years to mark those people to say, this one really counts as turnover. This one really counts as turnover, to then go ahead and calculate your retention and turnover rates so that your board of directors and your other leaders can really see what's truly happening to your medical assistant workforce. Next slide. So the path forward, what we're really considering is, again, we are really leveraging NIMAA as our primary academic partnership, mainly because we get to control kind of the externship experience at our health centers. They learn on our patients and our communities with all of our stuff and our equipment and our wave tests and everything else, which really prepares them to be able to hit the ground running here at CHC as a hired employee. Again, we're now participating in the two cohorts of our training program. And then, of course, we want to continue to participate in our local programs as much as possible and be really vocal about what are our needs as a customer, right? If they are preparing students to be able to function and work in our settings, they need to be able to think about how their programs need to radically change so that students are prepared and ready to go. We're expanding our ladder program and then also thinking about how we can leverage state and other training dollars. Oftentimes there's lots of money sitting in training programs for your state. It's just a matter of figuring out how is there a way that we can leverage that. And then, of course, thinking about additional staff where needs arise. I actually started with 2 float medical assistant positions, and I now have 5, one for every single region, because of the fact that I've proven that I really need at least one body to kind of plug those vacancies as they happen, because you just don't want your vacancy rate for medical assistants to match that of providers, or else you will never be prepared to really support your providers adequately. Next slide. Actually, you can go to the next one. So we went from a 2-step ladder to we're now moving to a 4-step ladder. And I've really integrated some of the coursework that has been developed through the NIMAA program, through the upskilling program. So our medical assistants do have some skin in the game, right? So each one of their steps is going to involve a professional development course, whether that is, at the entry level, the professionalism and training, in sort of professional communication, moving all the way up to them really thinking about how do I become an effective preceptor? How do I become an effective health coach so that I can support patients in behavior change? So really taking advantage of aligning your training with the competencies that you're going to require when they get to that ladder step, right? So there should be additional responsibilities tied to that next ladder step, as well as additional compensation, right? So you are going to see, hopefully, additional revenue dollars that are going to be tied to the additional data, the additional information that medical assistant is going to be collecting and delivering on, that you can tie directly to their specific staff level. So just some ideas and thinking about ladder programs. Next slide. So again, these are just some of the benefits to medical assistants, and then sort of the benefits to health centers in thinking about sort of continuing education and skill building for them, again, as a part of their process, and really also as a retention strategy to keep them interested in what they're doing at the health center. Next slide. So I think, Elena, at this point, I'm going to turn it back to you for a few minutes, and hopefully we'll have a couple of minutes for our Q&A.
I'm going to go really fast. So I think this is just sort of thinking about that pathway development piece and where medical assistants can be in that pathway. So we look here at some efforts that we're at NIMAA have provided in terms of the upskill classes that Mary mentioned that can facilitate moving up an MA pathway, but also as an accredited institution, working with other education providers in the communities where we serve students so that MAs with their certificate can then pursue an associate's degree or a bachelor's degree, getting credit for the work they've already done and move on into the positions that we often hear them say, right, are their long-term goals as a health professional. They want to go into nursing or they want to be a provider. It really that grow your own piece. This slide really illustrates the fact that medical assistants have training in a wide variety of areas, right? Billing, administration, coding, clinical. So the possibilities, everyone thinks about the nursing path as the clear medical path, right? If you ask any high school student if they're interested in medicine, nurse or provider. But there's so many ways that medical assistant training can be leveraged to support other roles in the health center. So as we're thinking about career pathway development and where those skills, and if you take a poll within your own entity and ask folks like who here started as a medical assistant, you might be surprised at what roles folks end up in, because that on the ground experience with the clinic flow and with patients and with the providers really gives them a perspective that is helpful in a number of different roles. Again, we'll send the slides out afterwards, but these are just some ideas of places where you can look for continuing education opportunities for medical assistants. There's lots of efforts going on in this area, including within the professional agencies of medical assistants where they get their national certification, state AHECs, your local PCAs, ACU and other entities, as they're looking at this workforce development, can help point folks in that direction. So, I think often we see that practices don't budget to support ongoing professional development for these roles, and with a little bit of a budget, there's certainly lots of options out there for professional development. These are the courses that we're offering currently for an upskill MA for NIMAA. The idea really being to help bring traditionally trained medical assistants, their skills and their understanding of the team-based care environment and practice within that, kind of up to what's needed for them to be effective in their positions. And a little bit about the pricing on that. So I'll stop there so that we do have time for questions, and knowing that we'll send these out otherwise. And I see a question, if it's okay, I'll just go ahead and answer it, about whether we've explored delivering MA training as an apprenticeship. Is that? So we have explored that. We have a couple clinical partners that do use NIMAA in the context of a broader apprenticeship. There are some challenges related to that. They're not unsurmountable. So it certainly can be a fit where it's the related training that's part of that apprenticeship model, and where the steps in apprenticeship that have those kind of step increases also in pay can align with completion of the NIMAA program, taking the certification exam, and then perhaps some additional competencies. There was a question earlier about sort of the wage scale and how that relates to experience, and I did have, let me see if I can get to my slide, early in the presentation, kind of the longevity of medical assistants in their role. So this is again from the ZIPA staffing. 28% of medical assistants are in their job less than a year, 30% 1 to 2 years, 13% 3 to 4 years, just 17% more than 5 years. So I think that's where this thinking about medical assisting as a pipeline avenue, both from other positions into medical assisting and from medical assisting into other roles within the health center, can be a real win-win.
Yeah. I think the only thing I'll add to that is just that, even in our experience and looking at our medical assistants, if we can get to year 3 with them, then they typically stay for 5 or more. So again, a lot of it is sort of what do you do in those first few years to really keep them engaged, give them opportunities for advancement, give them opportunities also for accountability, right? So if they are able to sort of see where they are and continually improve, and then see how that translates to reward and to, to merit, then oftentimes that will keep them engaged. I do often, so here there's another question that came in. Do you have any strategies to help retain staff that have burnout and are aware they can work non-medical jobs for the same wages that they get in the clinical setting? A lot of it, we actually most recently did a listening session with our medical assistants, and we were, did it as 2 30-minute sessions. We actually paid them extra time to do it. So we did right at the end of the clinical day where they could all zoom in on their phones, or, if they were home cooking dinner, whatever it was that they were doing, they could zoom in and give feedback. We were able to collect about 47 pieces of feedback around kind of job satisfaction, burnout from different workflows or inefficiencies. And then we kind of went back to our leadership team and said, okay, we need to resolve as many of these as we possibly can. And what's been exciting about that is, we were able to really address probably about like 28 of those things right out the gate as kind of the low hanging fruit. And then some of the other ones were definitely much more complicated. It was things like finishing the ladder program. It was, creating a centralized group to do diagnostic image tracking, right? Taking on a whole new department would be very challenging for the organization. But I think our medical assistants actually really appreciated the fact that there was communication and planning, and that we're continuing to do those sessions. So I have another one planned with them in March, just to do that ongoing listening. And believe it or not, and again, I'm knocking on wood because I don't want to jinx myself, but things have slowed down a little bit in terms of resignations. What I'm finding my biggest struggle right now is when I have to bring in temporary staff to cover FMLAs. We've had a lot of COVID babies and things like that. The quality of the staff that I'm getting from the agencies that we typically work with is just not the same that I had before. And so that has been very, very challenging. But I feel like we're getting better at identifying when things are becoming a problem more quickly. But I think if your MAs feel like they're listened to, you're working hard, even if you don't fix everything, they know that they're a priority and that they have folks who are dedicated to really trying to solve the issues that they're having.
And if it's okay, I just wanted to expand on that, if that was all right, because I thought that is an excellent response. And I think overall, Dr. Blankson, with what you mentioned, is at the end of the day, the organizational culture of respect is so important. And, many people, MAs, or really any type of provider, anyone in the health center, coming in, because this is, they're calling what they want to do. So that reminder of, just such an important role that you play on the team can go a very, very long way when it comes to burnout. But yeah, I didn't mean to just jump in, but I wanted to just add that.
No,
you got me thinking with the response that.
Yeah. I'm a huge fan of making sure that your organizational culture speaks value, right? And your organizational structure too, right? So I'm on an equal playing field with our chief medical officer. I don't report to her. She doesn't report to me, but we can't do anything without the other. I am a nurse practitioner. I have provider experience. So I think, we've really both kind of grown up at the health center, and we work very fluidly together. And I think oftentimes the nurses and the medical assistants feel like they have a seat at the table because of that. And it's not because our chief medical officer doesn't care about them or whatever, but she has a lot on her plate, and, caring about what's going on with provider affairs and other issues and kind of setting the clinical expectations for the organization is a lot. And so really carving out an additional leadership position that really is focused on those support staff and empowering that leader, I think is a really important piece of it. And I think we're seeing health centers and other primary care practices think about that and implement kind of, whether that's a nursing leader or whether that's an operations leader or whatever that might look like, really making sure that there are staff dedicated specifically to the success of all of those support teams.
Absolutely. And I want to say such a huge thank you to both of you. I was just keeping an eye on the time. And if there's any last comments you would like to make, please feel free. But I did want to get the chance to say thank you. And we're also going to be launching our evaluation in a moment. So before everyone leaves, if you could please fill it out, we would greatly, greatly appreciate it. Oh, there we go. I see that it just pulled up. But Elena, Dr. Blankson, thank you so much. And please, if you have any final comments, please go ahead.
Thank you for this opportunity to be here, and we're happy to talk more with anyone about these strategies. So appreciate it very much.
And for all the people that are going to listen to this asynchronously, we're happy that you listened to, and definitely feel free to reach out if you have questions.
Yep, and as we said, we will be sharing this recording for everyone who registered, and we will also be sharing the slides so you have all the information on there. And again, thank you so much for joining. I hope everyone has a great afternoon.
Everyone.
Thank you so much, Michelle.
Thank you.